Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 188 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, COK, a 62-year-old male patient presents to your surgical clinic with chief complaints of right hip pain, and an actively draining sinus tract 12 months post-right total hip replacement. The orthopedic surgeon declares that hardware revision or replacement is not possible, although a liner exchange is possible and feasible, during which she can obtain tissue and bone biopsy samples to guide postoperative antibiotic treatment. Cultures of these samples grow methicillin-resistant Staphylococcus epidermidis. So my question to you is, which of the treatment plans listed below would be the most appropriate for COK's initial treatment phase, assuming the use of IV vancomycin dosing to achieve a goal trough serum concentration of 15 to 20 mg per liter and an oral rifampin dosage of 300 mg orally twice daily? Would it be A. Vancomycin plus rifampin for 14 days, then doxycycline 100 mg orally twice daily indefinitely, or B. Vancomycin plus rifampin for 28 days, then doxycycline 100 mg orally twice daily plus rifampin to complete 3 months of therapy, or C. Vancomycin plus rifampin for 42 days, then trimethoprim sulfamethoxazole DS tablet orally twice daily plus rifampin to complete 6 months of therapy, or would it be D. Vancomycin plus rifampin to complete 42 days of therapy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Vancomycin plus rifampin for 28 days, then doxycycline 100 mg orally twice daily plus rifampin to complete 3 months of therapy. Vancomycin plus rifampin to complete 6 weeks of therapy is appropriate for a 2-stage revision in which all hardware is removed and re-implantation is planned. The patient in this case did not undergo a 2-stage procedure. Vancomycin plus rifampin for 6 weeks, then trimethoprim sulfamethoxazole DS tablet orally twice daily plus rifampin to complete 6 months of therapy is appropriate for knee, not hip, debridement and implant retention prosthetic joint infections. Vancomycin plus rifampin for 4 weeks, then doxycycline 100 mg orally twice daily plus rifampin to complete 3 months of therapy is appropriate for this patient who underwent debridement and implant retention (DAIR) for treatment of a hip prosthetic joint infection. According to the Infectious Diseases Society of America Prosthetic Joint Infection Guidelines, the antimicrobial selection and duration of therapy depend on 2 things: 1, the pathogen, Staphylococcus versus non-Staphylococcus, and 2, the hardware intervention. The appropriate duration of the initial treatment phase for Staphylococcus hip DAIR procedures is 3 months with rifampin added adjunctively. vancomycin plus rifampin for 4 weeks, then doxycycline 100 mg orally twice daily plus rifampin to complete 3 months of therapy is appropriate for this patient who underwent debridement and implant retention (DAIR) for treatment of a hip prosthetic joint infection. The IDSA guidelines encourage use of a long-term suppressive phase with oral therapy after the initial treatment phase as long as the hardware remains in place. 2 weeks of vancomycin plus rifampin is not consistent with the IDSA guideline recommendations. Please advance to the next question. And the next question reads, which of the statements listed below most accurately describes the role rifampin plays in the treatment of prosthetic joint infections? Is it A. Newer data suggest a role for rifampin in treating streptococcus and enterococcus infections when hardware cannot be removed, or B. Interactions between rifampin and other antimicrobial agents have not been associated with clinical failure in patients with prosthetic joint infections, or C. Rifampin 300 mg orally 3 times daily is the optimal dosage for treatment of prosthetic joint infections, or is it D. Rifampin is not recommended if hardware can be temporarily, that is for greater than 6 weeks, or permanently removed? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Rifampin is not recommended if hardware can be temporarily, that is for greater than 6 weeks, or permanently removed. The therapeutic benefit from rifampin is most pronounced in the presence of Staphylococcus biofilm on foreign devices. Prosthetic joint infections are inherently biofilm-related due to the presence of prosthetic arthroplasties. If the prosthesis is removed temporarily or permanently, the biofilm also is removed, thereby eliminating the need for an therapeutic benefit from rifampin. Although the Infectious Diseases Society of America guidelines for managing prosthetic joint infections recommend the use of rifampin 300 to 450 mg orally 3 times daily, the published literature supports a wide range of acceptable dosages, and there is quite a bit of variability in clinical practice. Many articles describe clinical success with the use of 600 to 900 mg orally daily. Patient non-adherence to prolonged, complicated antimicrobial regimens may be a problem because the activity of rifampin and other rifamycins is concentration-dependent, especially when treating Staphylococcus infections. Non-adherence could result in therapeutic failure. Therefore, dosing regimens that are as easy as possible for patients to adhere to are preferred. In several case reports analyzing small numbers of patients, clinical failures were observed when rifampin was administered with linezolid or co-trimoxazole for the treatment of bone, joint, or other types of infections. Pharmacokinetic data demonstrate a decreased ratio of the area under the curve to minimum inhibitory concentration of linezolid when the drug is used in combination with rifampin. A clinical trial of the use of fusidic acid in combination with rifampin to treat prosthetic joint infections was terminated early because of a drastic reduction in fusidic acid concentrations as a result of cytochrome P450 drug metabolizing enzyme induction by rifampin. The Infectious Diseases Society of America prosthetic joint infection guidelines do not address these drug interactions. Nevertheless, clinicians should be aware that clinical failure is possible when rifampin is used in combination with certain other antimicrobial agents to treat prosthetic joint infections. Adjunctive use of rifampin is not recommended for all gram-positive prosthetic joint infections. For example, data do not support the adjunctive use of rifampin for the treatment of prosthetic joint infections caused by enterococcus. Benefit from adjunctive rifampin use has been demonstrated only in a single report of a small number of patients with Streptococcus infections. The Infectious Diseases Society of America prosthetic joint infection guidelines support only the adjunctive use of rifampin for patients with Staphylococcus infections. Please proceed to the next question. And the next question reads, BCA, a 73-year-old female patient successfully completed 6 months of treatment with vancomycin followed by oral doxycycline for a right knee prosthetic joint infection caused by MRSA. The hardware was retained. Rifampin was added adjunctively. BCA's orthopedic surgeon would like to use long-term suppressive antimicrobial therapy in this clinical scenario. So my question to you is, which of the therapies listed below would be preferred for BCA according to the Infectious Diseases Society of America (IDSA) prosthetic joint infection guidelines? Would it be A. Doxycycline plus rifampin, or B. Trimethoprim TMP plus sulfamethoxazole SMX, or C. Clindamycin, or would it be D. Linezolid? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Trimethoprim TMP plus sulfamethoxazole SMX. According to the IDSA prosthetic joint guidelines, linezolid should not be used for long-term suppressive therapy in patients with prosthetic joint infections. Data supporting this use are lacking. Peripheral and optic neuropathy, which often are irreversible, and myelosuppression are associated with linezolid. Therefore, the risk of severe adverse effects outweighs any potential benefit. According to the IDSA guidelines, clindamycin is appropriate for the treatment of only methicillin-susceptible Staphylococcus aureus or Propionibacterium acnes infections when a penicillin allergy precludes the use of a beta-lactam antibiotic. Agents other than clindamycin should be used to treat MRSA infections. According to the IDSA prosthetic joint guidelines, recommendations 25 and 33, rifampin should not be continued beyond the initial treatment phase or used for chronic suppression. According to the IDSA guidelines, Table 3, TMP-SMX, i.e., cotrimoxazole, minocycline, and doxycycline are among the preferred antibiotics for long-term suppressive therapy for patients with prosthetic joint infections caused by MRSA. Therefore, TMP-SMX is appropriate for this patient who completed 6 months of initial treatment for a knee prosthetic joint infection caused by MRSA. Please progress to the next question. And the next question reads, in which of the clinical scenarios listed below is it most appropriate or indicated to use an oral antibiotic for the entire duration of treatment for a knee prosthetic joint infection, according to the Infectious Diseases Society of America (IDSA) guidelines? Is it A. Candida albicans infection following two-stage exchange, or B. Staphylococcus epidermidis infection without surgical debridement, or C. Escherichia coli infection following debridement and implant retention, or is it D. Methicillin-susceptible Staphylococcus aureus (MSSA) infection following one-stage exchange? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Escherichia coli infection following debridement and implant retention. According to the IDSA guidelines, an oral antibiotic with high oral bioavailability can be initiated on the first day of treatment for all non-Staphylococcus infections caused by susceptible pathogens. According to the IDSA guidelines, in patients with prosthetic joint infections caused by Staphylococcus, including Staphylococcus aureus and Coagules negative species, an initial 2 to 6 week course of intravenous antibiotic therapy is recommended if the hardware remains, i.e., no surgical intervention is used or debridement and implant retention is performed, or a one-stage exchange is performed. Oral therapy can be considered for the entire duration of treatment for Staphylococcus infections only if a two-stage exchange is performed or the hardware is permanently removed. The IDSA guidelines for prosthetic joint infections, written by Osman al., do not address Candida infections, but the IDSA Candidiasis guidelines, written by Pappas al., do. An azole antifungal agent or an echinocandin is recommended for prosthetic joint infections caused by Candida. The route of administration for azoles is not specified. Please advance to the next question. And the next question reads, DPA, a 53-year-old male patient underwent a left total knee arthroplasty 6 years ago due to avascular necrosis. He presented to your orthopedic clinic 14 days ago with a chief complaint of new-onset knee pain. The orthopedic surgeon ordered several tests and collected knee aspirate for analysis. Antimicrobial therapy was not started in the clinic. Regarding his past medical history, significant DPA is healthy with no major disease states. Regarding his social history, DPA was a smoker with a 10-pack-year history, but he quit smoking following the arthroplasty. His physical examination and labs reveal a maximum body temperature of 99.5 degrees Fahrenheit, a WBC of 5.6 times 10 power 3 cells per millimeter cubed, an ESR of 87 millimeters per hour, and a CRP of 114 milligrams per liter. His bone scan reveals multiple areas of inflammation, including both knees. Synovial fluid analysis reports are as follows: 1000 cells per millimeter cubed, 55% neutrophils, gram stain shows 1 plus WBC, 1 plus gram positive cacao in pairs, and no growth on culture media. Blood cultures show no growth after 5 days. So my question to you is, which of the findings listed below most strongly supports a diagnosis of prosthetic joint infection based on the Infectious Diseases Society of America (IDSA) clinical practice guidelines? Is it A. imaging, i.e., bone scan, or B. acute onset of a painful prosthesis, or C. synovial fluid analysis, or is it D. ESR and CRP? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. ESR and CRP. According to the IDSA guidelines, ESR and CRP should be included in the diagnostic workup for prosthetic joint infection. This is a level A3 evidence or recommendation. This patient has significant elevations in both values, which support a diagnosis of prosthetic joint infection. According to the IDSA guidelines, arthrocentesis is advised in patients with acute symptoms. Synovial fluid analysis, including gram stain and culture, total WBC count, and neutrophil count, is recommended. It is considered level A3. A neutrophil differential greater than 65% or total leukocyte count greater than 1700 cells per millimeter cubed have high sensitivity and specificity for knee prosthetic joint infection. This patient's values are too low to meet these criteria. According to the IDSA guidelines, the most important clinical symptom in patients with prosthetic joint infection is a sinus tract that communicates with the prosthesis. This is level B3 evidence. Acute onset of pain could be a symptom of hardware dislocation or prosthetic joint infection. The preferred type of imaging for prosthetic joint infection is a radiograph. This is level A3 evidence. The IDSA guidelines state that other types of imaging should not be routinely used to diagnose prosthetic joint infection. This is level B3 evidence. Therefore, this patient's bone scan results, which are nonspecific, do not provide strong support for a diagnosis of prosthetic joint infection. Please advance to the next question. And the next question reads, which of the following is a recent change to Food and Drug Administration requirements for clinical trials of drugs used to treat acute bacterial skin and skin structure infections, abbreviated as ABSSSI? Is it A. Use of anti-inflammatory medications with antipyretic properties is no longer permitted for pain relief, or B. A standardized duration of therapy of 7 days is now required for evaluation of shorter courses of therapy, or C. Patients receiving antimicrobial therapy up to 48 hours before evaluation for enrollment can now be enrolled, or is it D. Return of white blood cell, WBC count and temperature to the normal range within 72 hours is now required as the early response endpoint? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Use of anti-inflammatory medications with antipyretic properties is no longer permitted for pain relief. Reduction in lesion size by greater than 20% after 48 to 72 hours is now the early response endpoint. Fever resolution was the early response endpoint in 2010, but it was removed in 2012 because some patients, especially the elderly, do not mount a fever as part of the response to skin infections. Patients receiving antimicrobial therapy up to 48 hours before evaluation for enrollment are not necessarily eligible for enrollment. The 2010 guidance limits prior antibiotic therapy to clinical failures, single doses of short-acting antibiotics 3 or more days before enrollment, treatment of an indication other than ABSSSI using antibiotics that are inactive against pathogens causing ABSSSI. The 2010 FDA draft guidance for industry on developing drugs for treatment of ABSSSI do not require a specific duration of therapy, although both guidance documents discuss the need for evaluation of short courses of therapy. Corticosteroids and nonsteroidal anti-inflammatory drugs have been shown to impact fever and lesion size. Therefore, only short-acting antipyretic medications for fever, and analgesic drugs without antipyretic activity for pain, are allowed, particularly in the first 72 hours after ABSSSI diagnosis. Please proceed to the next question. And the next question reads, KAP, a 27-year-old male patient is readmitted due to left lower extremity surgical wound dehiscence with surrounding erythema. IV vancomycin was initiated promptly, and blood cultures remained negative 2 days later. Today the microbiology laboratory reports a wound culture positive for MRSA with a vancomycin MIC of 2 mg per liter. KAP's WBC count is 8.3 times 10 power 3 cells per millimeter cubed, and his maximum body temperature is 98.9 degrees Fahrenheit. So my question to you is, which of the vancomycin therapy recommendations listed below would be the most appropriate for KAP at this time? Would it be A. Increase the vancomycin dosage to achieve a serum trough concentration close to 20 mg per liter, or B. Discontinue vancomycin due to the elevated MIC, and switch to alternative antimicrobial therapy, or C. Continue vancomycin with dosage adjustment as needed to achieve a serum trough concentration greater than 10 mg per liter and monitor for clinical improvement? Or would it be D. Add clindamycin 300 mg orally 4 times daily as adjunctive therapy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Continue vancomycin with dosage adjustment as needed to achieve a serum trough concentration greater than 10 mg per liter and monitor for clinical improvement. Although the adjunctive use of clindamycin with vancomycin is appropriate for Group A Streptococcus infections, the benefits have not been shown to outweigh the risks for Staphylococcus aureus skin and soft tissue infections. The current Infectious Diseases Society of America MRSA guidelines (LUA-AL) do not support the routine use of combination antimicrobial therapy. According to a consensus review by the American Society of Health System Pharmacists, the Infectious Diseases Society of America (IDSA), and the Society of Infectious Diseases Pharmacists, published by Rybak et al., targeting a vancomycin serum trough level greater than 10 mg per liter is recommended to prevent the emergence of resistance. The 2011 IDSA-MRSA guidelines, published by Liu et al., address growing concerns about therapeutic failure of vancomycin when the MIC is 1.5 to 2 mg per liter, particularly in patients with bacteremia caused by Staphylococcus aureus. Switching from vancomycin to alternative antimicrobial therapy is recommended if the MIC exceeds 2 mg per liter. Continuing vancomycin with monitoring for clinical improvement for up to 7 days is recommended if the MIC is at or near the breakpoint of 2 mg per liter. In this patient with a mild infection, an MIC of 2 mg per liter alone should not prompt the clinician to switch therapy. According to a consensus review by the American Society of Health System Pharmacists, the Infectious Diseases Society of America, and the Society of Infectious Diseases Pharmacists, published by Rybak et al., targeting a vancomycin serum trough level of 15 to 20 mg per liter is recommended for patients with serious infections. Skin and soft tissue infections, particularly in the absence of fever or leukocytosis, are not considered serious infections. Moreover, the use of high vancomycin serum trough levels increases the risk of nephrotoxicity. Therefore, increasing the vancomycin dosage to achieve a target serum concentration close to 20 mg per liter is not appropriate for this patient. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 189.